I have no disclosures, except perhaps this personal disclosure, perhaps a bias, that my field experience has mainly been Uganda and other African countries. My main focus has been the most under-resourced countries and communities, where children and their families do not have access to even the most basic of surgical care. In these circumstances, the burden of limb deformity in children is unimaginably vast. The Lance Commission on Global Surgery in 2015 showed us starkly that 5 billion people on planet Earth do not have access to safe and affordable surgical care. 33 million individuals annually will face financial catastrophe in paying for their surgery, and many will not seek care at all because they cannot afford it. The disease control priorities of the World Bank identified 44 essential surgical procedures that would make the biggest difference globally in public health. They identified 3 levels of surgical care that we need to train: community primary health centers, first line and district hospitals, and tertiary referral hospitals. There were 10 procedures of orthopedic priority, mainly trauma and infection, all very basic skills, including fracture reduction, placement of an external fixator and the use of traction, debridement of osteomyelitis, and club foot repair. Having universal access to these basic services will reduce the burden of limb deformity in children and adults dramatically. The reality of most of the North-South orthopedic partnerships, where most of us put our energy, primarily focus on tertiary training in academic centers, teaching and training what we know and practice best. Often the new technologies we introduce are expensive, are reliant on sourcing expensive implants,